I'm Perry Weinstock, the Chief of Cardiology at Cooper, and the host of Cardiology Grand Rounds. So this week, we're really delighted to welcome one of our own, one of the folks who's been an integral part of Cooper for many years now, Dr. Kathleen Heintz. Let me give her a more formal introduction. So Dr. Heintz had her undergraduate training at Ohio State University, and she actually got a Bachelor of Science in Nursing degree from Ohio State and worked as a nurse. Some of you may not know that, but she worked as a nurse for a few years before she went to the University of Pennsylvania for a post-bac, and then went to Philadelphia College of Osteopathic Medicine for her medical degree. She was then intern at Atlantic City Medical Center, so she knows our whole South Jersey region very well. After Atlantic City, where she was the chief intern, after Atlantic City, she became an internal medicine resident at Abington Hospital in Philadelphia, and then came to Cooper for a cardiology fellowship. And she was just completing her fellowship just as I left Jefferson to come to Cooper. Dr. Heintz was one of our senior fellows, and she was so outstanding that we recruited her and kept her in our program. So she's been an attending here since the year 2000. And we're really grateful that she came to Cooper. Her background is in general cardiology, but many may not realize that she's had a special interest in anticoagulation and has served on our Pharmacy and Therapeutics Anticoagulation Subcommittee for many years. And so I invited Dr. Heintz to talk to us about an update in anticoagulation. Every few years she's done that for us. And there's always some new things that are coming along with the use of DOACs, now with COVID, how to reverse anticoagulation. So Dr. Heintz is going to give us an update on anticoagulation. Dr. Heintz, welcome to Grand Rounds. Thank you.
Okay.
I also just want to show everybody there's a form today that's a CME form. This is a CME program. Dr. Heintz has no disclosures, but you should fill out this form. It came online so that you all get credit for the CME. So thank you very much. Without further ado, Dr. Heintz.
Hi, Perry. Thank you for inviting me. And like Perry said, I've been around for a long time, but still have some very exciting stuff to share. I've done these anticoagulation grand rounds probably 5 or 6 times over the past 10 years, and all I can say is my slides change all the time. I have a few oldies in there, but most of this is new stuff. Now let's see if I can get this to move. Let's see. I can't get my slides to move. Like,
you have to click on the screen on your computer and see if it
comes up at the bottom. Oh, I found it down here, I think.
Yeah.
Okay.
Yep.
Okay. So we will discuss the timeline from really starting in 2010 till now. Today I'm going to talk about DOACs and VTE, including a deep vein thrombosis and pulmonary embolism, and I'm going to include some updated things on COVID. I'm going to talk about DOACs and atrial fibrillation and coronary artery disease, and I threw a few slides in there on PAD as well. I'm going to talk about DOACs and reversal, including Cooper usage. Well, what will we not discuss? We're not going to talk about warfarin, maybe a little bit. We're going to touch on it in some of the trials, but I'm not going to talk about reversal or use of warfarin. I'm not going to talk about acute hemodynamically significant PE and lytics. That's Leo's world. I'm not going to talk about anticoagulation with TAVR. That's Aji and Simon's world. And I'm not going to talk about anticoagulation for structural heart problems. That's Sajad's world. So I'm trying to stay in my lane here and give you updated things. We're going to mostly talk about rivaroxaban and apixaban because those are the agents that we use the most. We have a little bit of dabigatran use and edoxaban use, but not much at all. I always like to start off with this slide because it's so interesting. Like if you think about it, you think about once a day dosing of rivaroxaban. If you just looked at the half-life of this, you would say, hey, why would we give it once a day? But you also have to look at how it's metabolized. You have to look at not only the drug interactions, but primarily the protein binding. 90% protein binding with rivaroxaban. That means it leaves our system more slowly. So this is a really important slide when we're trying to choose an agent. Now, please don't let your eyes glaze over on this. I'm not going to stay on it long. But you know what? This gives us a really good idea about where our drugs come in. And if you see, I have outlined in yellow. You know what? It was easier to come up with a reversal for dabigatran because where it is in the cascade. It's pretty late, right before prothrombin goes to thrombin. So that's why we were able to come up with something to reverse it a little bit sooner. If you see where the 10As come in, including rivaroxaban and apixaban on the left, it took a little bit longer to get that. Interestingly, and I'll talk about it later, there's probably some synergy with other, platelet activity and other things elsewhere in the cascade, but we'll talk about that a little bit later. So it's really been 10 years since we've been talking about DOACs. When they first came out by 2011, both dabigatran and rivaroxaban had the indication for non-valvular atrial fibrillation. You know what? Dabigatran came out and they were kind of asleep at the wheel, and their management just didn't do the right thing, and they got a lot of bad press initially. And rivaroxaban really took over in terms of what they got indications for at that time. They had prophylaxis for knee and hip back in 2011. Fast forward to 2014, you see dabigatran, rivaroxaban, and apixaban all have non-valvular atrial fibrillation. And both dabigatran and rivaroxaban VTE, and then 2 of them for prophylaxis for hip. 2015, basically, everyone got everything for the most part. And if you come to 2016, pretty much everyone has the indication for almost everything. I'm going to start with VTE just because we don't talk about it quite as much as we do, let's say, PE, as we do using the DOACs for atrial fibrillation. And I'm going to focus on the ASH, American Society of Hematology, who just came out with their recommendations. But I'm going to start off with a case study. This is actually one of my outpatients, a 59-year-old male presented with right leg swelling after a car trip. Only risk factor, hypertension. An ultrasound demonstrated thrombus in the right femoral vein. A DOAC workup was completed, which demonstrated he was homozygote for the prothrombin gene, the mutation. What is the optimal medical therapy and for how long? If we start off looking at the trends, these are the trends of the DOACs to 2016. It's really hard to get the trending data. There's really not much past 2016, 17, 2018. But as we see in yellow, warfarin use has come way down. As we see, the total DOAC use has gone up. Here, rivaroxaban was more than apixaban. These numbers are changed because nationwide, more people are using apixaban than rivaroxaban. And as you see, the 2 numbers at the bottom for edoxaban and dabigatran, they've stayed basically flat. If we look at the trends for all comers, not just VTE, but atrial fibrillation, if we look at the US trends against UK trends, I have data out to 2017 in the US and to 2018 in the United Kingdom. So if you look closely, you see the warfarin slowly coming down, although it's come down even further over the past couple of years, really for both countries. And then you'll see apixaban use, rivaroxaban use, but these numbers don't really reflect what we're seeing now in our hospital, and I'll go through some of those trends as well. So the American Society of Hematology, they released updated guidelines in October 2020 for the management of VTE. Many significant changes which impact our daily practice came out, and I'm going to go through those. So just to get an idea of what this encompasses, VTE, 1 to 2 in 1,000 patients, or up to 300,000 to 600,000 a year. 1 in 100 of our patients over the age of 80. And up to 1/4 of patients will present with sudden death. So that's why this is a big deal. We see a higher incidence in the African American patient and lower in Asians. Primary risk factors for our VTE: medical hospitalizations, patients in long-term care facilities, and post-surgery. They came out with 28 recommendations. I'm not going to go through all 28, okay? I'm not that bad. But I'm going to go through the major ones that impact us. And they talked about primary treatment, secondary prevention, and treatment for recurrent VTEs. They prioritized the outcomes according to importance for clinicians, and they weighted their recommendation. So each of the recommendations comes out with, with a lot of evidence or a little evidence, with certainty or non-certainty. So, time frame. They call initial management from the time of diagnosis, let's say in the hospital or the ED, through the first 3 weeks of therapy. They call primary treatment up to 3 months, secondary treatment after the first 3 months, and extending for a prolonged, usually an indefinite period of time. For an uncomplicated DVT, ASH now recommends offering home treatment over hospital therapy. So you have a patient come to the ED, they're diagnosed with a new blood clot, they're going to be sent home, probably with medication. This doesn't apply to patients who require hospitalization for another reason, have limited support at home, can't afford the medication, or have a history of poor compliance. Although I agree with it, there's a lot of ifs to that, and it may not represent the patient that we generally see in the emergency room who may not have this. For PE with low risk of complication, they recommend home treatment over hospital treatment for PE. So the same thing. You're diagnosed with a PE, which is uncomplicated. You're sent home with medication. So how do you decide if somebody's high risk or not? The most reliable tool that we use is the PESI score, and Leo's talked about this also. It's been the most widely validated tool that we have. It's good, but it's a clunky score. I'm supposed to remember this, like you add 10 for some things, you add 30, you add 20 for other things, and you come up with a total. But this is probably the most validated tool that we have. You can look at the HAS-BLOOD score, which will help you balance what the risk of bleeding is against the risk of thrombosis. And again, not as clunky, but hypertension, renal disease, stroke, bleeding, labile INRs, elderly, and drugs or alcohol. And yes, there is an app for that, so you can carry it around and look it up that way. So ASH also came out and they recommended for both DVT and PE that they recommend a DOAC over a vitamin K antagonist, and this is new. They've never done this before. So before they were equivalent, and now they're recommending a DOAC over warfarin. It may not apply to those with renal insufficiency, and they usually call a creatinine clearance of less than 30, or if somebody has moderate to severe liver disease or the antiphospholipid antibody syndrome. And I think many of us, or many of the hematologists now, are using the DOACs for some of the other diagnosis to be anticoagulated for, but antiphospholipid antibody syndrome is still one that requires warfarin. This I thought was pretty big, because for DVT and PE, they do not suggest one DOAC over the other. So they didn't come out in favor of one over the other. So the stroke prevention wars continue. The other factors which may impact the choice, if you think about it, both dabigatran and edoxapan, when they were approved with a parenteral lead-in. So technically, if you're going to use those, you have to do IV heparin for 5 days prior, which kind of defeats the whole purpose. But that's actually how they were approved. So the other thing, lead-in anticoagulation, if the patient has cancer, once or twice a day dosing costs, or frankly, whatever their insurance covers. Now, for proximal DVT, they suggest anticoagulation alone over thrombolytic therapy, even for a proximal DVT or a very big DVT. Thrombolysis, they said, may be reasonable for a life-threatening DVT with, wait for it, phlegmasia ceruleus dolens, which literally means painful blue inflammation caused by like a thrombotic occlusion of some of the smaller vessels. This usually involves the iliac and common femorals. These patients may be at a higher risk for a post-thrombotic syndrome. Lytics, we should use them rarely for a DVT which is limited below the common femoral vein. So if they're a little higher up, it may be reasonable to think about thrombolysis, but for the most part, we're not using lytics unless it's very, very proximal. For PE, and here's Leo's world. I swear that's his picture from high school graduation. Yeah. For PE with hemodynamic compromise, ASH recommends thrombolytic therapy followed by anticoagulation. And they really didn't go into detail. They weren't totally enthusiastic about catheter specific thrombolysis, catheter-directed thrombolysis. They kind of hedged on whether they were more in favor of systemic or catheter-based. For a submassive PE, and we look at this all the time on echocardiogram, we're looking at the right ventricle, we're looking at the septum to see if it's bowing one way or another. We're looking for, we're looking for the waveform in the pulmonic valve to try to decide, like the pulmonary acceleration time, to try to decide if it's hemodynamically significant. But ASH recommends for a submassive PE where you may have those findings and you might have biomarkers such as a troponin or a pro-BNP consistent with RV dysfunction. Without significant hemodynamic compromise, they still suggest anticoagulation alone, not thrombolytics. For patients who have a proximal DVT and hemodynamic compromise, they still just recommend anticoagulation. They are not in favor of IVC filters. If a patient is unable to receive anticoagulation, let's say they're actively bleeding or for another reason, they recommend a retrievable filter to be taken out as soon as possible when the patient begins anticoagulation. So primary treatment of DVT, ASH suggests using a shorter course of anticoagulation, 3 to 6 months versus a longer 6 to 12-month course. On the previous recommendations, they had recommended a longer course for DVT. And again, we're familiar with the dosing. If you're using rivaroxaban, you have to use the 15 milligrams twice a day for the first 21 days and then switch over to a 20 milligram tablet for the next 3 months. If you're using Eliquis, apixaban, it is the BID dosing for 1 week and then switching. It's the 5 milligrams, it's the higher dose of the apixaban for 1 week and then switching to the 5 twice a day. So they next describe secondary prevention. And they're talking about from, the time of, the first diagnosis, that initial 3 weeks, until probably the first 3 months, like we talked about. Long-term anticoagulation with the intent to prevent VTE reoccurrence. Indefinite anticoagulation is suggested for most patients with an unprovoked event or those who have a provoked event with a chronic risk factor, such as a malignancy. For patients with risk for anticoagulation, like for instance, you have a patient who it's going to be kind of risky to give them anticoagulation, or they're unsure if they want to, or they're fighting you, they don't want to receive anticoagulation. You could look at a D-dimer, or you can look at an ultrasound for residual thrombosis. They don't recommend D-dimer and ultrasound on a routine basis, just for those questionable cases that you have. For patients needing long-term secondary prevention, anticoagulation is suggested over aspirin alone. If you are going to use warfarin for secondary prevention, they recommend an INR of 2 to 3, just like for AFib, over a lower INR. So that would be an indefinite 2 to 3. For secondary prevention, a standard dose DOAC or reduced dose DOAC. So you can, like for instance, somebody is on rivaroxaban 20. You can actually continue that. You can actually continue it for an additional year. But you can, after the initial treatment, for secondary prevention, you can go to the lower dose. So you can do a rivaroxaban 10 daily or an apixaban 2.5 daily. For a breakthrough on therapeutic, like if somebody does use warfarin, if there is breakthrough, they do not recommend to go to a DOAC. They recommend low molecular weight heparin. This does not apply in the setting of patients who aren't taking their warfarin, who have poor INR control because they're not taking it. Those patients may be more appropriate for a DOAC. And this, for me, is a game changer. What they say is for patients who are on long-term therapy for DVT and PE, who are also on aspirin for stable cardiovascular disease, ASH suggests suspending aspirin for the duration of anticoagulation. So for our patients who are on DOACs, technically this is for VTE. Does this apply to our patients on DOACs for AFib? Tough call. But they suggest suspending aspirin for the duration of the anticoagulation. I think you've seen some of my patients who are on anticoagulation. If they were also on aspirin, sometimes I'll take their aspirin to Monday, Wednesday, Friday. But I don't really have data on that. I know it decreases bruising. At the same time, I don't think I've had an increase in events. But we still don't have a recommendation in terms of AFib, but certainly for DVT and PE. This does not apply to patients with a recent coronary event. Those patients are still, they should still receive aspirin. So our boiler engineer, he received rivaroxaban for 6 months. He was seen by hematology, who felt his heterozygote prothrombin gene status did not put him at lifelong risk for recurrence. If you look at that data, it increases it slightly. Many patients who have this don't even know that they have it. So they opted for low-dose rivaroxaban for an additional 12 months. And that, it doesn't exactly follow the guidelines, but that's a reasonable approach for this patient. Although they don't necessarily recommend it, this patient continued to wear specialized Job stockings, which helped greatly with his post-phlebitic syndrome. Just a little bit about COVID. Case study for this, 62-year-old salesman who contracted COVID from his partying, non-social distancing, non-mask wearing Gen Z son, who happens to be my son's best friend. Thank you very much. His viral illness worsened, requiring O2. He was hospitalized at Cooper, received IV steroids and remdesivir. He did not have a VTE in the hospital, but was minimally active at the time of discharge. Anticoagulation or not. So we do have Cooper University Healthcare COVID-19 anticoagulation recommendations. They were implemented urgently in the spring and updated in September 2020. As with most hospitalized patients, it recommends prophylaxis for all COVID patients with sub-Q enoxaparin or sub-Q heparin. It suggests therapeutic anticoagulation for those found to have a DVT or a PE, or those with a high clinical suspicion of those, such as a rising D-dimer, acute worsening of O2, acute drop in blood pressure, tachycardia, high dead space ventilation, asymmetric limb swelling. And you might say, well, why don't they just make the diagnosis? Well, if it's a COVID patient, you may not want to send them down to the CAT scanner. You may not want to do some additional testing because of their COVID status. So if you have a high clinical suspicion, it's probably indicated to go ahead and give them therapeutic anticoagulation. And again, in the hospital, we use enoxaparin or unfractionated heparin, depending on the creatinine clearance. For patients receiving therapeutic anticoagulation in the hospital, 3 months of anticoagulation upon discharge is recommended. And as Brett was talking about last week, what we are seeing is just more microemboli, and the 3 months of anticoagulation upon discharge is for the patients on therapeutic anticoagulation, not necessarily those who were given prophylaxis. For discharge, a DOAC is preferred. If not feasible, therapeutic low molecular weight heparin is recommended. So for patients without a confirmed or highly suspected VTE, but with continued risk factors such as immobility, going to a nursing home, extended out of the hospital prophylaxis may be considered. So these are patients who still aren't walking around much, not exactly bedridden, but aren't back to their normal level of activity. They recommend rivaroxaban 10 milligrams daily for 15 to 30 days, enoxaparin 40 milligrams sub-Q daily 15 to 30 days, or apixaban 2.5 Q12 for 15 to 30 days. So our sales guy, he was discharged to home on a steroid taper, gradually increased his activity. I lent him my pulse, that's a typo. I lent him my pulse ox to monitor his O2 at home. He eventually recovered and has returned to work. He was discharged home on rivaroxaban 10 milligrams daily, which he took for 30 days. So just briefly talking about atrial fibrillation, because we covered this in February 2019 when new guidelines came out. The American Heart Association, the ACC, and the Heart Rhythm Society came out with combined recommendations in February 2019. And really, it was an update of the 2014 guidelines and just a few changes. We talked about it a year and a half ago, but I just put a couple slides in about it. They redefined valvular atrial fibrillation as moderate to severe mitral stenosis or a mechanical heart valve. So we can still use a DOAC in our patients who have moderate mitral regurgitation or moderate tricuspid regurgitation, or maybe they have moderate aortic stenosis. We can still use a DOAC in those patients. Edoxaban was added to the eligible NOACs, and this is the only paper that used the abbreviation NOAC as opposed to DOAC. The NOACs were recommended over warfarin, class 1 level of evidence A. They stated anticoagulation should be based on the CHADS-VASc, not on the rhythm necessarily, with AFib being paroxysmal, persistent, or permanent. Renal function or hepatic function should be checked prior to initiation. Bladder should be treated as fib. And they changed it slightly when they came out with the CHADS-VASc for recommendation of anticoagulation. They said men 2 or greater, women 3 or greater. So it changed it a little bit. So no real changes in those guidelines that I know of since then. So I'm going to talk about DOAC use in coronary artery disease. So 20 to 40% of patients with atrial fibrillation present with coronary artery disease. A sizable number of those require revascularization. There's many decisions regarding dual antiplatelet therapy and triple antithrombotic therapy. Some people refer to as TAT, even though I don't think it's that commonly used. So here's our case study. An 88-year-old retired press operator with permanent AFib on rate control with metoprolol and apixaban 2.5 BID for stroke prevention. He was appropriately dosed with his age greater than 80 and a creatinine of 1.6. He had an abnormal stress test with anterior ischemia. I attempted to treat him medically without success. He was admitted for a complex intervention to the LAD and then discharged to home. He was discharged on aspirin for 7 days, clopidogrel, and apixaban 2.5 daily. In order to look at atrial fibrillation and coronary artery disease looking at DOAC use, I reviewed primarily papers from 2019 and 2020. I stuck to the state-of-the-art papers from JACC and a few other publications. My primary focus, the primary focus of this JACC article or review was on pre and post coronary intervention, weighing the risk of bleeding against the risk of thrombosis. The JACC review included, they talked about WOST, a couple other trials. The ones I'm going to focus on, I'll say a few words about WOST, a few words about Pioneer AF, and a few words about Augustus. Initially, WOST, they looked at 531 patients on warfarin, and they looked at clopidogrel plus aspirin versus clopidogrel alone in PCI. It was a really small sample, 500 patients, but it provided the initial evidence that early discontinuation of aspirin reduced bleeding without any apparent change in ischemic events post-PCI. Pioneer looked at 2,000 patients on warfarin versus two different regimens of rivaroxaban with P2Y12 inhibitors, primarily clopidogrel, with or without aspirin. The arms were a little confusing, and I'm just going to go over them briefly. The top arm, rivaroxaban 15 milligrams plus one of the antiplatelet agents, rivaroxaban low dose BID plus DAPT, just for the actually the initial 1 month, and then rivaroxaban 15 milligrams with low dose aspirin. And then in the bottom arm, using full dose warfarin plus DAPT, and later on just warfarin plus low dose aspirin. So it's a little bit of a confusing regimen. And I have to tell you, on both arms where they used one of the antiplatelet agents, 90% of it was clopidogrel, very little prasugrel, very little ticagrelor, and they followed them for 12 months. And again, this is just what we went through. So what did it show? The top one shows reduced bleeding in both the rivaroxaban groups when compared to VKA. So the top group is the rivaroxaban group at the lower dose, showing, the two bottom groups are the rivaroxaban groups showing less bleeding than in the warfarin group, which isn't that surprising. There were very, very equivalent major cardiovascular events. So this demonstrated in 2,000 patients that the ischemic events were about the same with a little bit less bleeding. Augustus looked at 4,000, almost 5,000 patients on warfarin or apixaban, again using the P2Y12 inhibitors with or without aspirin. They randomized their patients to two arms, apixaban or warfarin, and in those two arms, either aspirin and placebo or aspirin and placebo for both arms. What did it show? It showed major bleeding was higher with warfarin plus aspirin. It showed that major bleeding was the lowest on apixaban and placebo. So if we did not, the curves varied right here. So apixaban and aspirin, their events weren't quite as high as the warfarin group, but the lowest group was the apixaban and the placebo group. Death and hospitalization, pretty equivalent. So their conclusion was in patients with AFib and a recent acute coronary syndrome or a PCI treated with a platelet inhibitor, an antithrombotic regimen that included apixaban without aspirin resulted in less bleeding and fewer hospitalizations than without significant differences in ischemic events. So the overall recommendation, which is interesting, and I haven't been doing this, so again, this changes my practice. They recommend a period of a DOAC washout of 24 hours, maybe 48 hours with a reduced creatinine clearance prior to elective PCI. Now, this doesn't apply to an acute coronary syndrome or an acute MI. Obviously, the choice of which antiplatelet medication or what the interventionalist is going to use it at the time, it's up to them. But we can prepare our patients for intervention by maybe holding our DOAC for 24 hours, just to give them a little bit more flexibility, perhaps. They recommend a peri-procedural and in-hospital use of aspirin, or 1 month in patients at very high thrombotic risk and a low bleeding risk. So almost nobody is getting aspirin in addition. So, and they also went on to say that pre or peri-procedural clopidogrel is recommended. Lifelong DOAC preferred over warfarin if warfarin is used, an INR of 2 to 2.5 while on DAP. So they don't recommend a 2 to 3, they recommend a 2 to 2.5 if our patients are on a DOAC. They prefer clopidogrel with ticagrelor as an alternative, and they recommend to avoid prasugrel if your patient is on a DOAC. They recommend to discontinue DAPT at 12 months in most patients. So our elderly press operator, unfortunately, 3 days following his intervention, he was readmitted to the CCU with shortness of breath and a drop in hemoglobin, developed a rapidly expanding effusion, taken to the cath lab for a pericardiocentesis. Unfortunately, he continued to bleed with tamponade, and he continued to expand despite blood products and drainage. Although reversal was considered, the wife ultimately made the decision for comfort care because she said he never really would want that. So why would they say just Plavix and not one of the others? And it may have to do with the synergy. And, we think of the DOACs as, affecting thrombus and fibrin. And it's a busy slide, sure enough. But if you look at the bottom of the screen, this is where we usually think the DOACs work. But if you look at the feedback back and forth to our activated platelets more at the top of the screen, there probably is some synergy between them. So even though we think we're giving a DOAC for atrial fibrillation or DVT, it's also probably affecting that thrombin formation. And it's probably that the synergy of the other two agents is just a little bit too strong. So just a couple slides on, I'm doing okay on time here, a couple slides on coronary artery disease and PAD. As you know, we're starting to look at what we call polyvascular disease, patients that we know have coronary disease, peripheral arterial disease, and cerebral vascular disease, carotid disease, lower extremity. The COMPASS trial looked at 27,000 patients at 600 sites. Primary outcomes being cardiovascular death and stroke, and secondary outcome being limb ischemia. And they looked at these doses. They looked at rivaroxaban 2.5 daily along with aspirin, rivaroxaban 5 milligrams daily, and aspirin daily. Now, this is for patients who may have had an intervention. They may be on aspirin and Plavix. At the end of the year, when you're taking them off Plavix, should you consider continuing just aspirin, or is there something that might be better? So this is why the trial was done. What they did find is the arms with rivaroxaban, actually the best arm was the rivaroxaban and the aspirin. So if you look at the cumulative risk of cardiovascular events, death, and stroke, your best one was with rivaroxaban and aspirin. If you look at the PAD cohort of that against overall, if you look at these, although some cross the line, some have a wide interval, so it may not be, as reliable. If you look, everything sort of is favorable to the left to be on rivaroxaban plus aspirin at the risk of bleeding. At the bottom of the screen, we see major bleeding. So we do see a slight increase in major bleeding if we do use rivaroxaban, but they went on to say that it was bleeding, it was bleeding not in, it was not significant neurologic bleeding. So there was an increase in major bleeding, but a decrease in events. And I just wanted to talk a little bit about our reversal and some women in our program, past and present. So this is our DOAC usage at Cooper. It used to be we would use a lot more rivaroxaban, whereas, as you might imagine, we're using a lot more apixaban. I won't say 3 times as much, but about 2.5 as much apixaban as rivaroxaban. And this is all comers, all doses for all reasons. Very little dabigatran use and virtually no edoxaban use. I'm going to talk a little bit about the reversal agents that we have here. We're all familiar with the PCCs, the prothrombin complex concentrates. The primary one that we use at Cooper is Kcentra. We are using a Dexanet alpha for 10A reversal now, and I'll talk a little bit about that. We do have idaruciximab, which is Praxbine, for dabigatran reversal. So the PCCs, they were initially approved for warfarin reversal. We use them off-label for DOAC reversal. And, you know, it's actually standard of care in most hospitals to have DOACs. We've had them around forever for hemophiliacs, but we are using them off-label for DOAC reversal. The average cost of one of these is $7,000. As we said, we use the 4-factor PCC at Cooper, factors 2, 7, 9, and 10, otherwise known as Kcentra. Idaruciximab came out about 3 years ago, approved only for dabigatran reversal. They priced it well below the PCCs, but again, not used much because our use of dabigatran is so low. Andexanet alpha, which I talked about in February 2019, it was approved as a 10A inhibitor reversal. The average cost is $25,000 for the low dose, $50,000 for the higher dose, depending on when their last dose of a DOAC was. And like I made the point a year and a half ago, that's the price of a pretty fancy car. It was added to the Cooper formulary in June 2019 for uncontrolled major bleeding for reversal of these two agents within 18 hours of the last administered dose in patients with a life-threatening bleed. These are patients who are getting everything else thrown at them. They are getting resuscitated, and they have major life-threatening bleed that they're going to die from. So if you look at our PCCs on the left, prothrombin, the PCCs, which have been around forever, Andexanet and idaruciximab, the total amount in the past 2 years is in the second column. In 2019, we used a lot more PCCs at 99. In 2020, we're using less PCC at the expense of Andexanet. As you see, we used 3 doses in 2019. We used 17 doses in 2020. And we've used very few doses of idaruciximab, a total of 5 over the past 3 years. I'm going to do a few slides just on how Andexanet works. It was released in February. It offered additional real-world patient information. Actually, the study was released in February. It evaluated 325 patients with acute major bleeding within 18 hours of factor 10 inhibition on DOACs. The primary outcomes, and again, we don't have a lot of long-term outcomes. I know Dr. Cha is going to ask me about that. Primary outcomes were change in the factor 10 activity and excellent or good hemostatic efficiency at 12 hours. They looked at life-threatening bleeds with hemodynamic compromise, and that is hypotension, poor perfusion, mental confusion, and low cardiac output. They looked at bleeding with a drop in hemoglobin of at least 2 grams or a hemoglobin less than 8. bleeding in a critical organ, they upped the ante by putting in intracranial hemorrhage. They were preferentially enrolled to enrich the study with these very high-risk patients. So the efficacy outcomes, we're looking at the anti-factor Xa activity and percentage of patients which stopped bleeding. The primary safety outcomes were death, thrombotic events, and developing antibodies to treatment. It demonstrated hemostatic efficacy in 82% compared with 72% in the earlier PCC studies. 14% of patients still died at 30 days, primarily thrombotic events when their anticoagulation was not restarted. And those death rates were very similar or slightly less than the variable results that we saw in some of the PCC studies. So what dose do we use? It depends on the timing. If the dose is within less than 8 hours, we're probably going to use the high dose. If it's greater than 8 hours, we're probably going to use the low dose. What does our dosing look like at Cooper? About 60% of people who have gotten andexanet have gotten the low dose. 40% have gotten the higher dose. And this is in the past, data from the past 1 year. It's a total of 20 patients. If you look at it month by month, we had a pretty big month in October. This is the use over the past year. Who got it? It was primarily CNS-related hemorrhages. So these are neurosurge patients going for urgent surgery. So 16 of them, or 80%, were CNS, and the rest were trauma or hemorrhagic shock. And then who got the most reversals? And this was kind of surprising because the last time we looked at it 2 years ago, it was different. Most of them, and it's probably because the use is a lot higher, were for apixaban. 5% were rivaroxaban, about 90 were for apixaban, which kind of goes against all that GI data, which suggests that rivaroxaban has higher bleeding. So we do have an anticoagulation reversal set. It is kind of hard to find, and we're working on that, being able to find that a little bit more. And I'm going to end with this. I found this in the archives. So the Cooper Anticoagulation Committee will continue to look at agents, see what's appropriate for the formulary to put on or to take off. And if you look at this was back in the day when I was a PGY6, right there on the far left with my badass mom Bob there. And Dr. Datwani in the middle, PGY4. I don't think you guys know the rest of these people, but that was my PGY6 picture. Okay, so I will open it up to discussion.
Kathleen, this is Leo. Can you hear me?
I can hear you, Leo.
Hope everyone else. No, thank you. Well, a very nice, broad-based discussion of the newer agents and our use of reversal, which is always very important in a big study like ours. A question and comment. The nice thing about the low dose Xarelto and 10A inhibition for the vascular and cardiac patients is more recently we've been able to risk stratify who gets the greatest benefit from that agent. Obviously, there's inertia to use it in everyone with coronary disease and such, but we as doctors have to identify patients at a higher risk. So it is that polyvascular, it is that renal insufficient patient in conjunction with polyvascular, and it is that polyvascular who has diabetes, and those are, when you kind of put those people together, renal insufficient, diabetic, polyvascular, and think I can't remember the last one, but there's a fourth one that really those patients get the greatest benefit from a aspirin plus low dose Xarelto therapy. The question I have for you is more related to double and triple therapies. What the data you presented with respect to aspirin and Xarelto, or aspirin and apixaban post PCI. Was there a time frame for aspirin removal from that triple therapy? I don't know if you presented that, but wanted to get your thoughts to see what the data suggests.
I think on the in both of the trials, you know what? It differed on both of the trials on how long they left the aspirin on, but you know what? I let that screen go. I'll have to check it out. You know, the hematology guidelines say in hospital and then stop it, or at the most 1 week and stop it if you think it's somebody, you know, at high risk for, you know, a stent closure. So I'm thinking the recommendation is 1 week. On Compass, I think they did it for a little bit longer, and Augustus, I think they did it for a little bit longer.
I don't, you know, it really also depends upon their clinical presentation. So if they're an outpatient coming in and going back as an outpatient, I think it's very reasonable to be a week or just a few days. It's the ACS, the STEMIs, that I think that in our world we look at triple therapy for maybe a month, and actually a month was recommended, I think, in Pioneer, and to discontinue the aspirin after the month. We had a case here where there was a STEMI and there was fear of bleeding, and they did discontinue the aspirin, left them on the P2Y12 and the apixaban, and the patient closed their stent. So that always rings in my ears as a result. You can't base your practice on patients, but at the same time.
Yeah, but I think that, you know, all those recommendations that came out from the American Society of Hematology, they're not for the acute patient. They're not for your acute coronary syndrome patient. They're for elective patients coming in with coronary disease.
Agreed. Hence the comment. Thank you, Kathleen. Well.
Thank you. Anyone else?
Other questions out there?
No question, just a comment that was a really great comprehensive lecture. I definitely learned stuff that I wasn't clear on, and you should have that, like, we should post that somewhere so we can review it later too.
Okay, thank you. I think all of these talks are posted somewhere. I'm just not sure where.
The Grand Rounds is actually recorded. Yvonne is recording it now, but I understand what Dr. Mazzarelli is saying. I thought it was an excellent talk also. And we could benefit from that throughout the year to remind each other.
I see on the call are Lauren Ignari and Anne-Marie Cristiano. They're the pharmacists who work on the Anticoagulation Committee with me. Is there anything you wanted to add or, you know, add to the presentation, or anything I might have missed from your perspective?
Hi, this is Anne-Marie.
Hi.
I just wanted to say I don't have anything additional to add, but thank you for having me. And also agree with everybody else's comments that this is very comprehensive and very educational, so I appreciate it. Thank you.
Okay.
I have a question that it's a tough one, but maybe you could just give us a common sense approach. You know, all of these NOACs have, as you said, you know, they each started with individual recommendations for when they can be used, but more or less they overlap in all areas from DVT to PE, AFib, etc. So how is one to decide, you know, do you have a way that you think about the NOACs when you're reaching for one?
Yeah, and I think all of us have ones that we use more than others. I think, you know, one of the reasons I don't use dabigatran quite as much is, you know, it probably is a prodrug and it needs to go to the liver to turn to an active drug. So many of our patients are on other medications, so I think I'd probably stay away a little bit from dabigatran. If you look at the safety data on dabigatran, it's almost identical to apixaban. But see, apixaban, you know, they're smart. And when they did their trials, they did their trials with the reduced dose, the 2.5, and they separated out those high-risk patients who were older with a low body weight with a reduced creatinine. And that's why their safety data looked better than everyone else, because they separated out those high-risk patients. So that being said, I think, you know, we primarily have what's covered by insurance, either rivaroxaban or apixaban. And I think we base it by patient. If the patient's on BID drug already, sometimes we'll go with apixaban, especially if they have a history of a GI bleed or other bleeding problems. I think Xarelto probably has slightly more bleeding than apixaban does. If I have a patient on relatively few medications and I want to go with once a day dosing for Xarelto or rivaroxaban, I think it's good, but you have to dose that with your largest meal, and for many patients, that's dinner. So many patients take their medications in the morning, and now you're asking them to take something with dinner. So I think that's my common sense approach when I have a patient and I'm trying to choose a drug.
Excellent, excellent. I don't know if there's any other questions. Go ahead.
Simon.
Hi, Simon.
Yeah, do you hear me?
Yes.
Hello?
Hi, Simon.
Yeah, just thanks for the hi. Just thank you for chip in. And the US didn't update their guidelines for ACS, but the European Society of Cardiology updated their guidelines for ACS non-STEMI not long ago, within the past month or two. And the way they address patients with AFib and PCI in the setting of non-STEMI ACS, they obviously look at the ischemic burden versus the bleeding risk. Okay, their default strategy will be to use triple therapy the first week if possible, and then after the first week, you have to decide: are we having high ischemic burden or high ischemic bleeding risk? And if you have high risk of ischemia with relatively low to moderate risk of bleeding, you try to go with triple therapy for a total of a month, and then you drop one of the antiplatelet thereafter. If you have high bleeding risk, then you do triple therapy for a week, and then you drop to double therapy after a week. This is just the recent guideline from the ESC from 2 months ago.
Yeah, I think, you know, for an acute event, I think unless it's a very unusual patient, I think 1 week of aspirin or putting that aspirin on at least during the hospitalization. But it's so hard. It is so hard when you have somebody come in, you know, with a bleeding problem. And I think we have more bleeding problems than we do post PCI events.